Okay, let's begin. Hi everybody, my name's Jeff Livingston and I'm with Crohn's and Colitis Canada. I'm so glad that you could all take out time from your Victoria Day long weekend to join us this evening. In addition to being the Queen's birthday, it's also World IBD Day. And I couldn't think of a better way to celebrate it than by sharing some of our educational tools with you all. I'll be moderating today's webinar and posing your questions to Dr. Silverberg at the end of today's presentation. So, without further ado, let's get on to some housekeeping items. Today's educational webinar on probiotics and nutritional supplements for Crohn's and colitis, hosted by Crohn's and Colitis Canada, is made possible through an unrestricted grant from Ferring Pharmaceuticals. Some of you may be new to webinars, so I'll quickly run through how you can ask questions and how they'll be answered. Right now, everyone is muted so that everyone can hear the speaker, and so we can capture this webinar recording without audio interference. If you look on the right side of your screen in the middle, you will see a field that says questions. You can ask questions to Dr. Silverberg by typing into this question box. Feel free to submit your questions anytime throughout the presentation. We will make note of the questions and present them to Dr. Silverberg once he's finished his presentation. So please feel free to type out your questions as you have them, and I'll read as many as we have time for during the Q&A portion of our webinar. If we don't get to your question, please feel free to follow up with us at learn@crohnsandcolitis.ca. And if you have a technical question, you can always type it into the question box and we'll follow up with you directly. Great. Now, with that out of the way, let's get started. Crohn's and Colitis Canada, formerly known as the Crohn's and Colitis Foundation of Canada, CCFC for short, was established in 1974 by a group of concerned parents of children with Crohn's and colitis. We are a national charity dedicated to finding treatments and cures for Crohn's and colitis and to educating people with these diseases. We want the general public to be aware of these often debilitating chronic diseases and the toll they take on the nearly 250,000 Canadians living with Crohn's and colitis. We also want people living with these diseases to be as well educated as possible to live well with their disease and make informed decisions about their treatment and rights. To date, Crohn's and Colitis Canada has funded over $82 million in medical research. That makes us one of the largest funders of Crohn's and colitis research in the world. We have more than 65,000 supporters, many of whom are actively involved in our 80+ volunteer groups or chapters across Canada, and many of whom have joined us today. Today's webinar is part of Crohn's and Colitis Canada's education program, which includes live education events, patient brochures, and our website. Our education materials cover a variety of medical, social, and psychological issues related to Crohn's and colitis. We have brochures covering issues specific to children with Crohn's and colitis, ostomy care, fertility, and intimacy, among others. Now, I'll leave it at that for now, but if you would like more information about Crohn's and Colitis Canada, please visit our website at crohnsandcolitis.ca. Now, I am pleased to introduce you to our guest speaker, Dr. Mark Silverberg. Dr. Silverberg is currently an associate professor in the Department of Medicine at the University of Toronto, a clinician, a scientist in the SLRI, and a practicing gastroenterologist in the Inflammatory Bowel Disease Group at Mount Sinai Hospital. Dr. Silverberg's medical practice is devoted to the care of patients with IBD. He participates in clinical trials and clinical observational research studies in IBD. He is also heavily engaged in training physicians and other allied health staff about the management of Crohn's and colitis. He is the co-chair of the Canadian GI Fellows Program in IBD, the program director of Advanced IBD Fellowship at Mount Sinai Hospital, and is the current chair of Crohn's and Colitis Canada's Scientific Medical Advisory Council. We are so very fortunate indeed that Dr. Silverberg will be speaking to us today about probiotics and nutritional supplements in Crohn's and colitis. So with that, let's begin, Dr. Silverberg.
Okay, thank you very much, Jeff. It's a pleasure to be here with all of you today. Hope everyone is enjoying the long weekend. And thanks for taking the time to tune in to this event today. It's a great way to mark World IBD Day, which I was pleased to see that there'll be events going on around the world today and around this time. So thank you again for listening. I hope you'll find it informative. So I'm going to start with a little bit of background just for those who aren't as familiar with the terminologies and the disease that we're talking about today. So the broad umbrella term is inflammatory bowel disease, and this does cover a variety of conditions, primarily Crohn's disease and ulcerative colitis. And I tend to use the term IBD a lot, and that's because as people have heard me speak before would know, I'm not quite as concerned about trying to separate Crohn's disease and ulcerative colitis. I think they are related conditions of a broad type, and that being IBD, and I'll try to get into that a little bit as I go along. So as you can see in this figure, these are the main differences between what we describe as Crohn's disease and ulcerative colitis. So on the left, you can see that Crohn's disease is a disease that can affect different parts of the gastrointestinal tract, ranging from the small intestine, the stomach, the duodenum, right to the end of the colon. And in the bottom part of the left side of the figure, you can see that the inflammatory process in Crohn's disease can affect the entire thickness of the bowel wall, such that there can be what we call penetrating complications, meaning that there can be abscesses and fistulas that arise. On the right side of the figure, you can see ulcerative colitis, which is a typically continuous type of inflammatory process that starts in the rectum and works its way backward through the colon, and it primarily only affects the colon rather than the small intestine, and the inflammatory process tends to be a more superficial process, and it doesn't get into the deeper layers of the bowel wall. Next slide, please. So in terms of the causes of IBD, we obviously don't know what the cause is, and there may be multiple causes of these conditions, but as you can see from this cartoon, it really implies that we really don't know, but there are multiple different avenues that we're exploring. So for example, on the left, genetic susceptibility, we think that's a very important underpinning in the cause of IBD, such that there are genes that are predisposing to IBD, and that really has been the focus of my research for the first 10 years of my career, and we've made excellent progress in identifying the genetic factors that are underlying the susceptibility to IBD. However, with much of that work having been completed and a really significant amount of understanding that's been gained in terms of the genetic architecture of the disease, we now have shifted our focus to the other side of the equation, which is the environment. And what aspects of the environment can trigger IBD or cause IBD in the setting of genetically susceptible individuals. And for example, you all know that there can be people affected, more than one person affected within a family, but many families have only one affected person. So it's clear that even people who may have inherited the same genetic architecture, the same genetic susceptibility as a family member, may not get the disease, and for that reason we understand that there are obviously other important variables that cause IBD. Next slide. So as we talk about the environment, there are multiple different environmental influences that could affect or trigger IBD or lead to IBD occurring. I'm not going to talk about all of these today, but just to highlight a few, smoking is an important variable, stress is an important variable, and oops, it shifted back into, the food, diet, and enteric gut flora is also quite important. And that's really the title of the talk, so I'm going to focus most of my attention on that area as diet, probiotics, food, and how that component of our environment may influence our susceptibility to IBD. Next slide. So how can the environment cause IBD? So as I just said, there's really two major ways to sort of oversimplify things a bit. One is a direct effect of a certain environmental substance. It could be a toxin, a chemical, something even relatively natural that's in our diet, such as gluten. Other examples, smoking is, I would say, is a toxin, has multiple toxins in it, and we clearly see a negative effect of smoking on Crohn's disease. I put fluoride there, not that there's really not any evidence recently that fluoride could cause IBD, but as an example of something that's been explored as potentially a direct effect. Gluten is an interesting one because it is a natural component in our diet. It's not an artificial chemical or toxin, and the typical or classical form of gluten intolerance is known as celiac disease, where people have an inflammatory process in their digestive tract that arises as a result of exposure to gluten. This is very different than what's known as gluten sensitivity, which is very popular right now, and probably many of you have tried gluten-free diets as a way to manage IBD. There really isn't a lot of evidence that it's effective, and it tends to be a transient benefit. But having said that, I think that what it raises is the concept that there can be a food component that's natural that can lead to an intestinal disease. And the second way that the environment may cause IBD is an indirect effect, and an example of that are the non-steroidal anti-inflammatory drugs, or NSAIDs. And again, I don't want to make you think that NSAIDs cause IBD, but on the other hand, they are significantly linked to the possibility that IBD may be triggered or worsened by these types of medications. And I've listed some examples there, like ibuprofen and all of its trade names, aspirin. These are medications that don't necessarily directly cause intestinal inflammation, but what they often do is lead to breaks in the intestinal barrier, so what we call increased permeability, and that may allow the leakage of, let's say, certain bacteria or other components in the digestive tract to get into and exposed to the immune system, which then could lead to gut inflammation. And another indirect effect of that I'm going to focus more on today is from our food, and that's going to be a major topic for me tonight. And what I want to highlight is that other than the example I gave above with gluten intolerance, there's probably a more significant way that food and our diet affects the risk of IBD or the possibility of flares of IBD, and that's by altering the composition of the gut microorganisms. And I'm going to get into that in more detail, but that's really, I think, going to be the major focus, and already is the major focus of research of many groups around the world trying to understand what causes IBD. Next slide. So to get into that, what I want to introduce to you is the term known as the microbiome, and that's a term you might have heard of the genome or the Human Genome Project. So scientists are quite into this omic terminology. So there was the genome, and now there's the microbiome, and what that refers to is the entire composition of the gut, bacteria, viruses, fungi, all of the smaller living organisms that we're playing host to on a daily basis. And as we embark on this type of research, we want to understand what is the role of this microbiome in health. And what's clear is that it's quite critical to our good health that we have a healthy microbiome, and I'm going to talk about that a little bit. I want to talk a little bit about how the intestinal microbiome can change, and to talk a little bit about this term called dysbiosis, which means having an unhealthy microbiome, and what the role is of, let's say, probiotics or diet in trying to restore a healthy microbiome. So next slide. So this is a figure that gives you a little bit of an understanding of what we think is the model for IBD occurring right now. and it's the interaction between genes and environment. So in the left column, you can see the human microbiome, and in row A, it says healthy microbiome. And so if you have a healthy microbiome and you have a gene that may predispose to IBD, you can see that on the third column that you have a healthy immune response. So your immune balance is still quite regulated. However, in panel B, if you have a dysbiosis, and you can see there's two examples of this. One is an increase in pro-inflammatory bacteria, or potentially a decrease in anti-inflammatory bacteria in the setting of the same genetic defect, that then leads to an imbalance in our immune response and an increase in pro-inflammatory molecules through our body. So this seems like a fairly reliable model of what causes IBD. The trick in this is that we now have a fairly good understanding of the genetic part of this equation, but we really don't have a lot of understanding on what is a healthy microbiome and what is a dysbiosis or an unhealthy microbiome. And so a lot of what I'm going to tell you is still early, speculative, and sort of giving you an introduction to where we're going, but we don't have a lot of hard evidence yet. But I suspect in a couple of years' time we will have a lot better detail on explaining what is a healthy microbiome and what isn't a healthy microbiome. Next slide. So your microbiome is your local environment. It's what's going on in your own body, and it may be surprising to some of you to know that you have 100 trillion microbes in your body at this time. And that's a pretty enormous number. It's actually a larger number than the number of human cells in your body. And so you're actually more bacteria than you are human if we count up by cells. So we really have a whole additional ecosystem that's living in our body. And it's not just in our gut, by the way. This is just the gut bacteria. There's a whole host of healthy bacteria living on our skin and other parts of our body. And these are quite critical, actually, to good health and maintaining health. But for many years, we weren't able to understand or measure what bacteria are there. As you can imagine, this is a very difficult thing to try to characterize such a large environment. And in the olden days of our previous technologies, we couldn't culture bacteria sufficiently accurately to measure this. And that was the prevailing technique for identifying bacteria for many years, is culturing them, the Petri dish. But nowadays, we can actually identify what's there in our bacterial genome by sequencing. So the same type of sequencing that we used for human genetic research, we're now using that technology in a very similar fashion to sequence the bacterial DNA that's in our body. And that's much more manageable, in fact, with our current technologies, to get the bacterial DNA from a stool sample, for example, or from a tissue sample taken at a colonoscopy, and to sequence it and then use a computer and a lot of smart people who are very good at analyzing this type of data to be able to give us a compositional readout that will say that certain bacterial species are either increased or decreased in your gut. And as you can see on this slide, there's about 500 distinct microbial taxa. Taxa meaning, for lack of a better term, a species or a distinct group of microbes. And each of these groups of microbes has very distinctive function. And in our normal situation, in good health, we need those bacteria to metabolize our food, to produce vitamins. They actually live off of the waste that travels through our gut, and including some of the food that didn't get digested on its way through and whatever's left over as it travels through it. And it's important to note that most of that bacteria is actually found in our large intestine and in our colon, and most of our small intestine in health is a relatively sterile community. Next slide, please. So one of the ways that the bacterial composition of our gut first came to our attention was through animal research. And as many of you know, we do use animal models to help us understand IBD and test theories about what causes IBD. And in this slide, the details aren't important, but what is just the big picture of all this is that if you look in the middle, there's various mouse models of IBD where they get gut inflammation. There are rat models, guinea pig models, and there's even a non-human primate model, which is perhaps one of the most useful models, but obviously fraught with some ethical issues. It's called the cotton-top tamarin. And it was discovered that this primate develops colitis when in captivity. And what's important about all of these models, whether it's the cotton-top tamarin or a mouse, is that if those animals are raised in a germ-free environment on the left, there is no immune activation and no inflammation that develops. However, when that animal is raised in a usual environment, and that's not to say an excessively dirty environment, just a usual, ordinary environment for that animal, they have bacterial exposure, then they do get inflammation. So what's clear is that bacteria, just in general, have a critical role in triggering and perpetuating inflammatory disease in the bowel. Next slide. Another hint that bacteria are important, and in particular healthy bacteria are important, is some recent data that's come out of New York that suggests that the number of courses of antibiotics that children get in early life could actually increase the risk of IBD down the road. And so the title of this article is "Stop the Killing of Beneficial Bacteria." And it does speak to a very, I think, a big problem in medical health right now, and that's the overuse of antibiotics. We really got addicted to antibiotics because of how effective they were, and they are still extremely effective at eradicating infectious disease. But as everything else in the world, nothing comes without a cost, and I think the cost of the profuse use of antibiotics may be an increase in other types of diseases, and in particular autoimmune diseases like Crohn's and colitis. Next slide. So this is a slide that shows some of that data that was published a couple of years ago that shows the number of courses of antibiotic and the risk ratio of developing IBD. And the numbers aren't too important, but just to show the trend that the more courses of antibiotics a child had, the higher the risk. And again, this is just a clue that bacteria are important and the composition of them are important, but we still don't, these are epidemiological clues and not causative findings that we can use to avoid or treat IBD. Next slide. So let's get into that aspect of things then. What do we know and what can we use, and how do we modulate our microbiome to be beneficial or to not be harmful? So before I get into this list, I would just say, to refer back to my last comment, if you're ill and you're seeing your doctor, I think we should be questioning our need for antibiotics. And there are certainly situations where antibiotics are appropriate and in fact necessary to save our life. However, we should be a little more, I think, discriminative about, and including when I say we, I mean as patients and as physicians, to prescribe an antibiotic only when it's necessary. The majority of the upper respiratory infections that occur in children and in adults over the winter are usually viruses, and antibiotics have very little role to play. So push your doctor and push your children's doctors about whether they really need an antibiotic, and if the doctor tells you they don't need an antibiotic, don't go looking for another doctor who will give you the antibiotic. I think we just need to be a little more cautious and not think of antibiotics as harmless products. Now, what can we do that's more proactive to change our microbiome? So these are 4 areas that I'm going to touch on to a greater or lesser degree. One is the category of probiotics or prebiotics. Another is nutritional supplements. The third is just our general diet. And the fourth is an area called fecal transplantation. So next slide. So first up, probiotics and prebiotics. So just to give you a definition, probiotics are live microorganisms which must be administered in adequate amounts to confer an effect on the host. And that's really important, two of those points. One is that the microorganisms have to be alive. And if you're taking good bacteria, or bacteria that you hope will be good, the one thing, if they're not alive, they're not going to last very long. They're just going to get degraded as they travel through your gut, and they won't do anything at all. And many probiotics out there are actually not live. So that is one thing to keep in mind. The other is that they have to be taken in adequate amounts. If you take a tiny amount of probiotic, the chances of it traveling all the way through your stomach, small intestine, and getting into your colon and being able to get a toehold there and expand and sort of engender some type of effect, then you need to take sufficient amounts to do that. And many of the dosages on probiotic bottles and packaging is not really designed or has not even been tested to know whether the amount that's recommended is an amount that is going to affect a change on the host microbiome. Now, I'm sure all of you are wondering, well, how do I know how much to take and what to take? And that's a problem. I'm gonna address that a little bit, but the fact is we actually don't know in many circumstances which ones are the right ones to take and how much to take, and that's one of the things that's problematic in this area, is we just don't know enough. Another area is prebiotics. So prebiotics are even a little one step removed from a probiotic, and that's a non-digestible food substance that can stimulate the growth and activity of a select number of microorganisms in the gut. And that's, to me, it's connected to what I'm going to talk about in a few minutes about diet. It's really using food to change our bacterial composition. And to me, this is one of the most exciting areas of IBD research right now. And you know, imagine that there might be an opportunity to understand that certain bacterial species, when they're present in high quantities, are pro-inflammatory, and you want to then increase the number of anti-inflammatory bacteria. And we know which ones those bacteria are, then we know that those bacteria really thrive on a certain type of food component that all we would have to do potentially is tell people to take, you know, a larger amount of that food, and they could potentially improve their gut health through a very natural process such as that, rather than using medications, prescription medications. So it's a little bit of science fiction right now to suggest that, but I can tell you that there's a lot of exciting research going on in different centers, including ours and around the world, to really try to get at this issue as quickly as we can. Next slide. So probiotics, as I said, they need to be live, and one of the ways to know whether a probiotic that you purchase is live is that it's usually required to be refrigerated. If it's not stored in a refrigerator, it probably isn't live, but it is something that you can inquire of the pharmacist or the product manufacturers that you're looking at. A big question is, are they safe to ingest? And a lot of people assume that probiotics are safe because you don't need a prescription, you know, why would they offer this without a prescription? Well, you know, it's been successfully marketed as a natural product. However, there have been side effects reported. I've seen patients get worse with probiotics and have their disease flare. And there's been rare reports of abscesses and infections that have occurred. So I think those are rare, and generally speaking, probiotics are safe, but they're not guaranteed to be safe. And I do recommend that people who are thinking about using probiotics to manage their disease should discuss that with their physician, including the types of products that might be beneficial and how much to take. And I'm not going to specifically make those recommendations on this webinar, simply because I think it's a nuanced area without a lot of evidence, and I think it is something that requires discussion with your own physician given your own circumstances. But there are some general areas that I could tell you where probiotics have looked like they can be beneficial. One is in the setting of the pelvic pouch, which is the surgery that's done for ulcerative colitis when the colon has to be removed and a small intestinal pouch is created at the bottom end. And there is evidence that taking probiotics can decrease the chance that you may develop a complication in your pouch, such as pouchitis, which is an inflammatory condition of the pouch. And there has been also some data that suggests that probiotics may be effective in the treatment of mild ulcerative colitis, and typically in combination with other medications like the 5-ASA mesalamine products. So I think what you can see here, and what I want to really stress, is that probiotics really are not appropriate in someone who's very sick. If you have severe disease, and I'm not going to go into all the definitions of that, but if you're very sick to the point where you may be requiring steroids or therapies like Remicade or Humira, or you're in the hospital, or you're so unwell that you're not going to work or to school, it's unlikely that probiotics will work in that setting. Where I think probiotics will have the most bang for the buck is in the setting of preventing flares and keeping people in remission. And that's when I usually recommend it, is when I'm seeing people and they're well and they're in remission. That's when we discuss that possibility, because I think the probiotics work best in the setting of the relatively uninflamed gut, when they really can have a chance to grow and to, again, get a toehold and really expand the population of that probiotic. But in the setting of severe inflammation of the gut is so diseased and damaged that it will not be able to grow in that situation. Next slide. So here are some of the other aspect of probiotics that's important, in addition to them being live, is when we say a probiotic, what bacteria are actually composing that probiotic. And for me, this is also one of the major issues that I have, at least with the current state of knowledge that we have, is that we really don't know which bacteria to put in these probiotics. They're typically filled with what we call non-pathogenic strains, so lactobacilli, bifidobacteria, streptococci are bacteria that you'll often see listed on a probiotic package. And those bacteria, we really don't know for sure that they are beneficial. We're pretty sure they're not harmful, but we don't really know if they help a lot. We just know that these are bacteria that are typically found in healthy people's colons. And so the theory is, well, if we give a lot more of these bacteria, maybe people will feel better. But really, I think this is guesswork, and it's not very scientifically driven in terms of the compositions of these probiotics, typically. They're generally tested to be safe, but not tested in any great detail in terms of whether they can actually achieve a health benefit in someone who has a health problem. There are also sometimes probiotics that contain non-bacterial organisms, such as Saccharomyces boulardii, which is a type of yeast. And this has also been suggested as potentially playing a role in keeping a healthy bacterial and microbial balance in the gut. But again, as you can see from the way I presented this, basically, we're throwing a bunch of bacteria into a capsule or into a pouch, and telling people to ingest it without really knowing whether there's a health benefit to be gained from these particular bacteria. And I do envision a time when we will be able to identify which particular bacteria are anti-inflammatory and need to be increased, and specifically target those bacteria to be more intelligent about how we do this. Next slide. So this is just an example of one probiotic product in a study that was done in ulcerative colitis. This product is called VSL3. and it is one of the ones that has been has very good quality control, so we know it has live bacteria, we know it has very large quantities of bacteria, and there was one study that showed that it was able to improve the inflammatory process in ulcerative colitis, but really we'd like to see more data on this, more study, and more validation that this is effective. Next slide. So I think I've made these points already, but just to know some but not all probiotics in adequate amounts will have beneficial effects. So I think ulcerative colitis right now has more of the data. There's really not any significant data that there's probiotic benefit in Crohn's disease. Prebiotics, it's the same thing. They probably stimulate the good bacteria that are present to increase their populations. There's a few sort of small studies and a series of a few patients that suggest a benefit, mainly in ulcerative colitis and not in Crohn's disease. Next slide. So this is an example of a prebiotic. So inulin is a component that's found in a variety of vegetables, as you can see in the bottom: leeks, artichokes, onions, asparagus, garlic. And what we know is that inulin can, in itself, directly stimulate certain bacterial components to increase, and presumably beneficial bacteria, although again, this is one of those areas where we start getting into a bit of a black box and not really knowing specifically which bacteria we want to increase. But this is where I think there's a lot of excitement by taking a food component and using it as a therapy by allowing it to increase the bacteria that we want to increase. Next slide. So now I'm going to switch gears a little bit and talk about some nutritional supplements, when you should take them and why. So this is a list of some of the nutritional supplements that might be of interest to people with IBD. And I'm going to touch not on all of these, but on a couple of them. I think one that I'm not coming back to later, which I'll just mention now, is iron. So iron is something that isn't needed as a supplement unless it's measured as deficient. So I guess that I should make the point that many people are concerned that they're deficient in all sorts of vitamins and minerals when they have IBD. And in fact, most of the time, unless people are very ill, they're completely nutritionally replete with vitamins and minerals. I want to highlight that almost all vitamins and minerals are absorbed in the small intestine, and primarily in the first half of the small intestine. So if you have ulcerative colitis and you're not in the hospital, it's very unlikely that you'll have any nutritional deficiencies as a result of your disease. In Crohn's disease, again, if you have Crohn's disease that affects the top half of your gut, then you may have nutritional deficiencies. But if it affects your colon or terminal ileum, the last bit of your small bowel, it's very unlikely that you'll have significant nutritional deficiencies. But I will get into, let me highlight a few examples. So next slide. So one interesting area is the omega-3 fatty acids. So these are supplements that are not necessarily deficient in people with IBD, but there's some suggestion that people who take a supplement to enhance the amount of omega-3 fatty acids in their gut, that they will benefit. And so there was one study in Crohn's disease showing a benefit. And I think generally it does seem that across several studies there seems to be a nutritional benefit to having a high fish diet, and in particular the cold water oily fish such as salmon, herring, mackerel, anchovies, and sardines, which are quite high in omega-3 fatty acids. Next slide. Vitamin D is another interesting one. So again, most patients with IBD are not necessarily vitamin D deficient because of their disease itself. However, it turns out that many people in Canada, for example, are vitamin D deficient, even healthy people. And that's because we live in a climate where, as you can see for the people in the Toronto area, we're not exactly having the sunniest May 2-4 weekend here. So much of the year we don't get sufficient sun exposure, especially in the winter. And so our vitamin D levels tend to be lower. And as you'll know, IBD tends to be more common in places like Canada. And in northern climates. And so that's what led to people think, well, you know, if IBD is more common in temperate climates, it must be because we're not getting enough vitamin D. So this is there's no direct evidence to support that, but it's an interesting theory. Your physician can measure your vitamin D level very easily and tell you whether you're vitamin D deficient. So it is one of those things that you might want to check before you decide you're going to take supplements. Maybe vitamin D may be actual anti-inflammatory. If you're lactose intolerant, you may not get sufficient vitamin D in your food. Fish is a great source of natural vitamin D. Again, so seeing the benefits of a fish-based diet, but you can also, of course, buy over-the-counter supplements that are high in vitamin D or quite effective at raising vitamin D levels. Next slide. Fiber, again, is an interesting one because it encompasses such a large number of components. There's soluble fibers and insoluble. So on this slide I'll talk about soluble fibers. And the benefit of soluble fibers is they tend to attract water and form a gel-like substance. And that does help slow emptying of the stomach and the colon, which gives you an ability to control your diet intake if you're overweight, which can happen in IBD. And these are some of the sources of soluble fiber, and they can have multiple mechanisms for how they might be beneficial for health, besides the fact that they may slow metabolism a little bit, and may have some direct benefits on bacteria by changing the bacterial composition of the bowel. Next slide. These are insoluble fibers. So insoluble fibers are considered healthy because they help as a laxative. So you may think that people with IBD don't need laxatives, but that's not always the case. In fact, people can be constipated with IBD. And these are some of the sources of insoluble fiber, including many things that are quite high residue foods. And so, again, this is an important area that you have to be in close contact with your physician before you make wholesale changes in your diet. For people that do not have strictures, which means a narrowing in their bowel, there is no problem to eat any type of soluble or insoluble fiber. Many people will read that in Crohn's disease they shouldn't eat fiber because of the risk of obstruction. And the fact is that if you don't have a stricture, and many people with Crohn's disease don't have a stricture, there's no problem to eat these foods, and in fact they're probably beneficial. So it's important to know whether you have a stricture or any narrowing in your gut, and in that case you will have to be careful with supplementing fiber in your diet. Next slide. So as I said earlier, you have to know your personal circumstances, your disease state, what disease you have, what the anatomy is of your current disease, and whether you have particular allergies and food intolerances. And the reason I put this up here is because, again, I want to emphasize that there is no one way to do this that's going to apply to everybody. There's a lot of individuality in people's circumstances of their disease and their symptoms and their gut motility. And so coming up with a strategy to use certain supplements and food components needs to be tailored to your individual situation. That's where you need good communication with your physician. Next slide. Another area that I did allude to a little bit before, but there is a fairly high rate of bone loss in patients with IBD, and it occurs at an earlier age. So that's osteoporosis, or mild osteoporosis is known as osteopenia. It is something that can be measured and checked with a bone density test. And again, I don't encourage everybody to supplement with calcium and vitamin D for that, but rather to be checked and discuss with your doctor whether you need to do this and to do it if necessary. Many patients with IBD avoid dairy products which are fortified in calcium and vitamin D, but it may not be the case that you have to do that. Many patients with IBD can tolerate lactose without any problem, and it doesn't do any harm to your gut. Next slide. One interesting area that I'll just highlight for you to show you some of the research that we're doing at Mount Sinai. So many of you may know that in Crohn's disease after surgery, there's a very predictable recurrence rate. So surgery doesn't cure the disease, and these lines kind of show you the rate of recurrence over time, such that, by, let's say, 3 or 4 years after surgery, about half of patients will have a recurrence. So what can we do about that? And that's another scenario where I think we have real opportunities to try to change the natural history of the disease using a natural approach, using food or supplements. Next slide. So we have some preliminary data because we've been doing a large study at Mount Sinai, and it's being actually expanded now across North America to look at the dietary factors that are associated with early recurrence. And this slide only shows you the data from our first 12 subjects, but we're well over 30 patients now, but we haven't analyzed the data again. But just to give you a sense of it, we found that people who had a diet high in butyrate, saturated fat, and folic acid that was a protective diet, and it was something that benefited in terms of preventing or slowing recurrence. So this gives you a sense of where we're going with this, and we really want to understand if we can see which food components are protective or worsening, then we can advise people more specifically. So when you ask us, what should I eat, we can give you better answers than we don't really know, which is what we're saying right now. Next slide. So the last couple of minutes or a minute or two, I just want to talk about a few other areas. So there are studies underway that are called dietary intervention studies. So these are studies that I just mentioned. One way we can do it is just observe the natural history and see what happens, like the slide I just showed you. But in fact, we finally have started doing studies where a prescribed diet is given, and then we see whether it actually has a benefit. And I'm part of a group in North America that's studying the microbiome with other centers in North America. And a component of our study together is actually to take, it's starting small, but to take 10 or 15 patients and provide them with a diet that has been engineered to try to take advantage of the information that we have about the microbiome, and to have these people eat only the food that's prescribed over a period of 6 months, and try to measure whether we see a benefit in terms of inflammation and in terms of symptoms. Many of you are probably frustrated with the slow pace of this type of research, but I can tell you that it is finally getting going, and it will, I think, really take off over the next couple of years. So we'll see a lot more research that's devoted to understanding how diet can be used as a treatment. The other area that's of interest to patients is fecal microbial transplantation. And with that, if you haven't heard of it, what it involves is taking stool from a healthy donor, and that could be a relative or an unrelated donor, and it's obviously tested for infection, and it's then infused into the patient either by enema. There are even some that are given through a protected capsule by mouth. And the idea or the principle of it is to try to repopulate the bacterial composition of a patient with IBD using a healthy person's bacteria. And it's an interesting idea. I must say I'm a little bit puzzled by how many patients are interested in this, because it really is a fairly broad approach without a lot of specific scientific knowledge to suggest that it should work, but because it's been so popular, I would say patients are really driving this research and the interest in it to the point where in the U.S. you can just go get it done. You can go to a clinic and just go have one through any physician. Well, not quite any, but it's certainly less regulated in the U.S. than in Canada. But again, I think it's the right concept, but the wrong way to do it. And I think we first need to figure out which bacteria are beneficial or harmful, and then use our ability to engineer bacteria, and we can do this, or provide dietary instructions that help with this problem, rather than just simply taking stool from somebody who's healthy and assuming that that's going to make a patient healthy. And actually, in fact, the results of the preliminary results of one of the studies that's being done in this area was presented at the recent GI meetings in Chicago, and the study results were negative. So there was no benefit seen with fecal transplantation and ulcerative colitis. Next slide. Okay, so I'm wrapping up a few summary comments. So how will we prevent IBD in the future? And that's really the goal here, is to prevent it. So on the right side, you can see the genetic risk of IBD, and although we have a pretty good understanding of all the genes that are involved, we aren't able to give gene therapy, and that's still not very easy to do, and we're not anywhere close to that. But where we can make an impact much more quickly is on the environmental side. And that's as we understand better the types of microbial components that are healthy or unhealthy, then there are many things we can do to intervene to either prevent IBD from occurring or prevent or potentially treating it. And those could be diet, probiotics, prebiotics, and things like that to change it. And I think there is potential to really accomplish this in the next few years, and I think you're going to see some very exciting developments in this area. Next slide. So I'll wrap up. Just I work at Mount Sinai Hospital in Toronto, and we do have a Center of Excellence in IBD that's focused really on all aspects of IBD: patient care, surgery, research, and for the patients that are coming through our center, we do get them very involved in these research projects, and probably pester them a little too much, but that's the best way to make progress in this disease, is to get active participation of our patients. Next slide.
Thank you, Dr. Silverberg. Great presentation. Before we get to the question and answer period, I wanted to remind everybody about ways that you can show your support for World IBD Day today. You can visit our Facebook page or website to download your own Crohn's and Colitis Canada Facebook cover photo and profile picture. Upload this image to your Facebook page to show your friends and your family that you support the 233,000 Canadians and millions worldwide living with Crohn's and colitis. And, of course, we have the Gutsy Walk coming up on Sunday, June the 8th. The Gutsy Walk, Crohn's and Colitis Canada's largest single-day fundraiser, is a fun and healthy way to support those in our community living with Crohn's and colitis. 1 in every 150 Canadians suffer from Crohn's and colitis, a rate that ranks in the highest worldwide. Proceeds raised advance medical research, improving the lives of children and adults affected by these chronic diseases, and ultimately find cures. The Gutsy Walk takes place in 59 communities across Canada on Sunday, June the 8th. For more information about a walk location near you and to register, please visit gutsywalk.ca or call 1-800-387-1479. And let's get to those questions and answer period. We've got some great questions. Let's start with one from Eric. Eric is asking, is there any value in taking the product Zyflamen, which is a combination of herbs known to reduce inflammation, like turmeric, ginger, holy basil, rosemary, and a few others?
Yeah, so that, I mean, to address that topic generally, so many people are taking supplements that involve various herbs and other food components. All I can tell you is the vast majority of them have very little scientific research, particularly in humans. Much of the research is very observational or anecdotal, meaning it's just thought to be effective, and there's some very sort of, I guess, loose ties to a potential anti-inflammatory mechanism. What I would say again is please, I'm not going to comment on that specific product, but talk to your doctor about it, do some research, and ask the manufacturer if you can, what scientific evidence is there that this product is effective in my situation?
Louise has a question saying, I have mild to moderate UC. Along with ASA and VSL number 3, would I benefit from taking one?
I'm not sure exactly what the question is, except I think that if the disease is under control and in remission, then that is a potential opportunity to try a probiotic to see if it will enhance your ability to stay in remission. I generally, again, encourage people to stay on a 5-ASA in ulcerative colitis because these are prescription medications which are quite safe and effective. But that might be a scenario where you would try a probiotic if you're in remission.
Okay, Eric has a question. For those without colons, how does a lack of living space for our microbiome, does it increase risks of relapse in Crohn's disease? Does it create other problems for ostomates?
Yeah, it's a great question. So people with Crohn's disease who have ileostomies tend not to get recurrence at very high rates, and we think that's because the bacteria can't easily repopulate the ileum because there's such a rapid flow through the stoma into the appliance or right through. And in the setting where we create a reservoir for stool, such as a pouch, an internal pouch or a colon, that allows bacteria to thrive, and that does seem to set up the inflammatory process more actively. So in general, people who have ileostomies tend to do better, but probiotics might be also effective in that situation to try to keep that part of the bowel populated with healthy bacteria.
Elizabeth's asking, if you've had your large bowel removed and replaced with a J pouch, will the small intestine then begin to house bacteria?
Yes, another excellent question. That's a lot of a focus of our research. So the short answer is yes. The pelvic pouch, which is made of small intestine, does become essentially another rectum once the colon's removed, and that becomes a reservoir for stool. And even though the ileum previously in ulcerative colitis wasn't affected by the disease, it seems like when people with colitis then have a pelvic pouch with an ileum, they get inflammation in that pouch, which they wouldn't have before. And we think the reason for that is because of the bacteria that are thriving in the pouch. So that's another example where a probiotic might be effective, because as soon as the pouch is created, by introducing a probiotic, you may be able to prevent any sort of negative bacteria from repopulating the pouch.
Roy's got a question. Roy's asking, are the probiotics that are on the shelves and stored at room temperature worth trying?
The short answer again is no. Typically those are not, don't have sufficient numbers of live bacteria. I can't comment on every product, but as a general rule of thumb, if it's not refrigerated, you don't have sufficient numbers of live bacteria to make it beneficial. But you could investigate an individual product and try to find out, if they do quality control testing to see how much live bacteria is present in their product.
Great. Kevin's got a question about omega-3. He's asking, is there any benefit to using omega-369 capsules as opposed to just omega-3? And what doses should be aimed for?
So I can't answer that specifically. I don't know enough about omega-6 or 9. To my knowledge, I don't recall seeing research in IBD published on those. I only know of omega-3 studies. In terms of the dose, so it depends on the product, and they really, it's difficult because each product has very different ways that they calculate their dosing. So I think it's one of those things that you have to individualize, but typically the doses are higher than what's on the packaging, and it's often doses that are quite excessive to the point that that most people would sort of think, oh, that's way too high. But when we look at the studies that have been done, the dosages are what we call mega doses of omega-3s. So they're quite large doses, and again, I can't give you a specific because each product has different ways that they calculate the dosage, but it is something that you should discuss with your physician.
Karen's asking a question. Karen's asking, post-ileostomy, what dietary recommendations would you make for post-surgery recovery?
So, that's something usually people get a lot of that information in the hospital from a dietitian, but in general terms, what we recommend is low residue diet, so low fiber, simple foods that are easy to digest. We recommend separating solids and liquids, and we also recommend that people eat smaller meals more frequently rather than large meals. And that usually we need to follow that type of diet for about 2 to 3 months, and then very slowly the ileum will adapt, and people eventually eat a fairly normal diet once their bowel has adapted to the ileostomy.
Great. We've got so many great questions. Here's one from Alana. Alana's asking, have you done much research in the area of the specific carbohydrate diet for people with Crohn's and colitis?
No, there hasn't been a lot of research on that particular diet. It's obviously well known to a lot of people. I think the issue with many of the different types of diets, as I mentioned at the beginning, they all seem to give people a little bit of benefit at the beginning, probably just because of a non-specific shift in the bacteria as a result of the dietary change. But what we do find is most patients who follow any of these diets the effect doesn't last long enough, and they do start to have recurrent symptoms within 6 months to a year, or they just find it very difficult to maintain the diet for a long period of time. So I certainly don't discourage people from trying these diets as long as they're not harmful and as long as they have a reasonable nutritional composition, but I have yet to see a specific diet that's out there that has had lasting benefit. But I would say there has not been sufficient research in any of them to be conclusive about that.
Naomi's asking a question about her 18-year-old daughter. She says, my 18-year-old daughter has UC and a J pouch. Does the prevention of pouchitis with probiotics curtail other inflammatory symptoms such as inflamed joints and poor circulation?
Yeah, it may. It will be difficult to tell you for sure, but I would definitely give it a try. It is possible that whatever residual inflammation there is driving some of those non-intestinal symptoms that she's having, and trying probiotics to affect change in the level of inflammation may improve those symptoms. So it's worth a try.
And Brent's asking, besides surgery, is there any way to address strictures that have been present for over 20 years in the small intestine?
I mean, it depends on the location of the stricture. So if it's a stricture that can be reached with a scope, we can sometimes do balloon dilatation of this stricture. The problem is that our ability to dilate it with a scope usually does not result in a long-lasting benefit, and it often will narrow down and stricture down within a year. So you can temporize with an endoscopy procedure and not have surgery. And if people can manage with dietary adjustments and lifestyle adjustments to the stricture, I don't necessarily think people have to have surgery, but there are a lot of individual issues around there, and I think the most important thing is to make sure if you do have surgery, to make sure it's being done by an experienced surgeon.
Great. And we've got time for one more question, and Kathy's asking, my child supplements daily with Boost or Ensure. Do I need to be concerned about the sugar content?
That's a good question. I think there probably is too much sugar in those supplements. However, it depends on the reason that the person's using those supplements. If it's because they can't eat solid food sufficiently to maintain their nutritional and caloric intake, then there's probably not too much choice, although there are a couple of products that can, including those ones that you mentioned, that can be found in lower sugar formulations. But if they're just using it as a supplement to a regular diet and it's not required for the basics of their nutritional composition, then it might be better to minimize it a little bit.
Great. We have such fantastic questions and so many of them today. I wish we could answer all of them. But as we're drawing near to the end, I'd like to take this opportunity to let everybody know that we will be following up with everyone after the webinar via email to get your feedback and any suggestions you may have on future topics. And I want to thank everybody for being with us today and for the great questions. I especially want to thank our speaker, Dr. Mark Silverberg, for taking time out of his busy schedule, and especially on this holiday Monday, to share his expertise and knowledge with us all. Also, thank you to Ferring Pharmaceuticals for supporting this webinar. Our recording will be made available for downloading on our website at crohnsandcolitis.ca/webinar. Crohn's and Colitis Canada also hosts education symposiums across Canada every November, so be sure to visit crohnsandcolitis.ca/symposium to find out more. Again, thank you so very much for joining us, everybody, and I hope we've helped answer some of your questions about living well with Crohn's and colitis. Dr. Silverberg, is there something you wanted to say?
No, thank you everybody for taking the time to listen. I hope it was useful and informative, and enjoy the rest of your weekend.
It was excellent. Thanks so much again for putting the presentation on, Dr. Silverberg. You did a great job.